Hi, my name is Kirk Hamilton, your host of the Staying Healthy Today show. This is a show to bring you key experts in the fields of nutrition, prevention, integrative, and lifestyle medicine for the individual, society, and the world. And I like to do interviews with people. Sometimes I'll talk on a topic, but today I have just a very exceptional guest, and the topic is going to be what is the role of the microbiota, Bifidobacteria, and vitamin C in the prevention and treatment of SARS-CoV-2 infection, long haul COVID, and COVID vaccination injury. And if I can sneak in a little about colon cancer, I will. But Dr. Sabine Hazan is the CEO of Ventura Clinical Trials. She's CEO of Progena in Ventura, California. And as I was going through her site, I tried to get, about the person, but I think I'll let her tell it because I was there forever and it seemed like I couldn't do it justice. So welcome, Dr. Hazan. Thanks for being on the show today.
Thank you, and thank you for having me. It's a pleasure. In a nutshell, I'm the girl that's a rebel. I think all rebels are scientists in the making, and I think I'm that girl. I'm the girl that questioned everything growing up, and I'm the girl that questions everything in science and in medicine, especially as we haven't reached cures in a lot of diseases, and these diseases are climbing up. So, I started off as a physician and a gastroenterologist, based, mainly on a challenge that they didn't take women in GI. So I said, well, I'll be your first woman. And then at University of Florida. And then from there, I kind of, ended up doing GI. GI was kind of the same routine, doing colonoscopies, gastroscopies, and I felt it wasn't enriching enough. I went to the clinical trial route of doing clinical trials for pharma because I felt that was a little bit more exciting, seeing new drugs for Crohn's disease, new drugs for psoriasis, new drugs for heart disease. And so that was exciting because it was always keeping me up to date on the newest stuff. When fecal material became a capsule of poop in the pharma world, and we had no idea what was the microbiome, what microbes are good, what microbes are bad, one could say I went rogue from doing clinical trials and started doing my own clinical trials on the microbiome because I felt that we needed to do the research the proper way. We needed to understand, there's a lot of things we know that we feel like, cumin helps inflammation, but how does it help inflammation, et cetera, et cetera. So I went into the path of the microbiome kind of on a quest to understand life, to understand disease, opened up a genetic sequencing lab. We do all our stool testing. Went from testing kids with autism to adults with Alzheimer's, Parkinson's, cancer, colon cancer, to the animals in the jungle, to, animals on a safari, and really trying to understand the microbiome, the microbiome of the elephant. Why is the elephant an herbivore? Why is a lion a carnivore? And really trying to understand all that. COVID really was the test that allowed me to really dig into the microbiome. And I couldn't believe that nobody was looking at the microbiome. And to me, it was sort of like, well, here we are, we're trying to fight a virus. A virus is a microbe. Viruses, bacteria, all commingle together in the guts of humans. How do we suppress this virus? And what bacteria suppresses it? And that was my path, right? That was the quest of knowledge. And so the microbiome just kind of opened up to me during the pandemic, really.
So, as a clinician, you saw the COVID experience happening in front of you. Were you seeing patients that drove you to find a cure, or you were thinking nationally, kind of how I'd help the bigger picture, but you saw patients in front of you? And then how did you, well, I guess you're a gastroenterologist, but how did you decide to look down into the microbiome to find a possible treatment approach?
So it started a little bit before because I was on this quest of trying to understand what are we doing when we fix C. diff with fecal transplant, right? And so I had brought together all these gastroenterologists that are, I call them my biome squad. And then I brought together all these functional medicine doctors to see what are those functional medicine doctors doing that are improving their patients that I'm missing, right? That I'm not doing on my patients and keeping them on biologics, right? So it started a little bit before. It started with Dr. Tom Barodi. Well, it actually started before with Dr. Feingold, who was the physician who started writing the book on anaerobic infections. From there, Dr. Barodi came into the picture. And he was supposed to speak at the Malibu microbiome meeting in 2020. That meeting, and he texted me, he goes, "Do you think that meeting's going to happen? Because look at what's going on in China." And that was in January 2020, right? We were already paying attention. I was coming back from abroad myself with my family and came home to, what's going on in China. And so he started looking at it. I started looking at it. We started paying attention. The meeting was missed, but the virus was coming to LA, sometime in March or even a little bit before we were starting. So we got ready into looking at everything that, he got ready by looking at the data, what was out there, and talking to a lot of pharmaceutical companies and seeing what was in the works. I got ready by calling my doctors on the clinical trial path and saying, "Okay, guys, what are you seeing?" And calling my doctors in Hong Kong, calling my doctors in Italy, saying, "Hey, what's working in Italy?" So that I could be ready here on the front line. And then France, right? And so we gathered, there were a bunch of doctors, about 300 of us, that gathered into an email blast. And we started talking about what do we think is the right treatment. And Dr. Barodi and I, because we come from a different path, he had a lot of patents. He worked with pharma. I came from the path of doing the clinical trials for pharma and essentially, knowing how to run a clinical trial and how to submit a protocol to the FDA. So we felt, well, between the two of us, he came with the patent world and I came with the, let's develop a product. Let's bring that product to market. Let's figure out COVID, right? And on top of that, I owned a genetic sequencing lab that was spearheading the microbiome with, a lot of clinical trials on the microbiome and diseases, because we were testing the microbiome of autism, Parkinson's, Alzheimer's, etc. So that was the work I was doing with Dr. Barodi to kind of see, hey, you're improving Parkinson's. What is improving? What microbes? Because in the microbiome space, in order to understand the microbiome, you have to attain a cure. In order to attain a cure, you have to practice the art of medicine. And in order to practice the art of medicine, you have to have courage to step outside of the guidelines. So it's step 1, 2, 3 process.
So yes. in focusing on COVID, were you looking for a pharmaceutical approach? Initially.
Yes. Initially, we came out with a pharmaceutical approach, right? We basically, Dr. Barodi, I came up with the hydroxychloroquine, Z-Pak, vitamin C, D, and zinc that became my patent. Because I saw the work of Didier Raoult. So I said, right, you know what? That's got some basics to it. I would think, like C. diff, we were thinking about it like C. diff, right? How did we attain improvement with C. diff? Think about C. diff, right? What we've done for the last 61 years until fecal transplant became part of the guidelines for C. diff, right? We started with a microbe that we didn't know secreted toxins. We figured out how a lot of, we had assays that helped us develop the technology to find those toxins that the bacteria created. We then tried to kill it with multiple antibiotics. And then when we did fecal transplant, the process of taking stools from a healthy donor to a non-healthy, we figured out, hey, feces help C. diff. How did feces help C. diff? Feces help C. diff by restoring the diversity that was missing, that was killed from taking antibiotics in that patient, right? That's why when you have people that are in the hospital, not everybody gets C. diff because some of them still retain the diversity. Some of them still retain all their clostridiums, all the good microbes, right? So when you have, and I mean Clostridium, good Clostridiums, there's good Clostridium, there's bad Clostridium, right? So when we discovered that you suppress C. diff with other microbes, other actinobacteria, phylum microbes, other Firmicutes, Bassiata, they call them now. That's when we said, okay, well, that's how we did C. That's how we fixed C. diff, right? We found the bug, we killed the bug with vancomycin, and then we replenished the microbiome. With COVID, it was essentially, how do we kill COVID without having to do fecal transplant, right? So in other words, what medication is going to kill the virus without killing the microbiome? Or what medication is going to kill the virus, but then I got to give it something else to up the microbiome, right? So it's in essence the art of refloralization. Refloralization is not just putting stools into the colon. It's the art of kill one microbe, grow another microbe, right? It's a new process and a new concept I'm bringing forward because I want people to start thinking about when you kill a cancer. And by the way, this didn't happen overnight. This was a progression of multiple, experiments, research, figuring out all this, surviving, COVID, treating all these patients, not having anyone die on my shift. It was really that, figuring out, wait a minute. So I'm looking at this the wrong way. I've got to start programming my brain to think of killing the bug, but restoring the bug that's missing, right? That's refloralization. So with COVID, I came up with the hydroxy Z-Pak, vitamin C, D, and zinc, figured out, hey, guess what? If I have a patient that we were the lab that found whole genome sequencing of COVID in the stools, as you've heard from, previous podcasts. When we discovered the virus in everyone, we also discovered that hydroxychloroquine wiped the virus. Here's the problem. Hydroxychloroquine also wipes your microbiome. So, when you talk about long COVID, are you talking about people that killed the virus, but then also killed their microbiome and therefore they can't get back
So
up?
the $74 million question, well, I have two of them. You just answered, you started to challenge me on my last question because I have colon cancer and I've been taking ivermectin and mebendazole for over a year and a half, 2 years. But that was my last question. But so how did you so you treated these people, you came up with your treatment. How did you
so we came up with a treatment. That was in April. We submitted that to the FDA. We actually submitted it in March, the protocol. We got approved to run it within 24 hours. And then the FDA came back and said, Dr. Hazan, you need to do a full-on protocol. Before that, they said, move to market, okay? So the FDA was on our side at the beginning and moved us. And then somewhere along the line, somebody must have called the FDA to stop that and make us do a full-on clinical trials, which to me was a bit ridiculous considering these drugs were used for, hundreds of years. I mean, at least 100 years. Hydroxychloroquine is an old drug. Z-Pak is an old drug. And forgive me, I don't know when they were created, but the bottom line is they were old drugs that we gave to millions of people with arthritis, millions of people with bronchitis. So to me, the idea of doing a full-on placebo-controlled clinical trial on 2 drugs and a bunch of vitamins was just ridiculous to begin with in the middle of a pandemic. But whatever, I did it. What I faced during the pandemic was really an awakening because I posted my protocol on clinicaltrials.gov, full transparency. Dr. Barodi and myself could have just put it as Haze-D-Pak and nobody would have known what's Haze-D-Pak. Much like Zyverdox, nobody knows what Zyverdox is. I mean, not Zyverdox, but Paxlovid. Nobody knows what Paxlovid is, right? So we could have easily done Haze-D-Pak, Zyverdox. Nobody would have known that Haze-D-Pak was had hydroxychloroquine in it. Nobody would have known Zyverdox had ivermectin in it. We did that in full transparency to showcase the protocol and save as many people as possible. When these protocols became politicized, divided, killed, my voice, all of a sudden, I couldn't recruit patients during COVID. When prior to that, by the way, I was the girl that was putting a post on Facebook and was getting 100 patients with psoriasis. I can't even recruit one patient with COVID during the biggest pandemic when there was people dying. There was something wrong there. So, and the harassment, the bullying, the discrediting me, the calling me names, those were things that I never faced. And the politicizing of drugs also I never faced. I was living in my bubble, I'll be honest. I was the girl. Yeah, no, I was the girl that was bringing drugs to market for pharma.
Hang on a second. Hang on a second. I see your passion. I see your passion. Maybe I'm making you go back. You couldn't have emergency authorization use for vaccines and such if you had repurposed drugs. That was the whole argument of why all these things had to be put down, correct?
Figured that as we were in the
Right, right. Okay. I mean,
and I
yeah,
think
that
all of us that all the doctors that treated, and by the way, all those doctors that treated off label were attacked. I mean, some of them lost their boards, some of them lost their privileges at hospitals, some of them had to fight their licenses. So all those doctors, were used as, examples of what not to do. I did things by the book. I had the board of medicine in my office and I showed them the protocols and I said, this is under FDA jurisdiction. This is research. You're interfering with research. I'm doing everything by the book. In fact, I was really upset that the board came to my office because of the fact that I did everything by the book to write these protocols, to submit them to the FDA, and to conduct the clinical trials. Aside from practicing the art of medicine, which we should be allowed as physicians, think about how many doctors are writing, a blood pressure medication combined with a cholesterol medication. Do we need to do a clinical trial combining these two? Because now you're adding another combination drug. So using combination drug has always been the art of medicine. It's been the art of a primary care physician that basically looks at your cholesterol and says, you need some cholesterol medication. Your blood pressure is high. You need some, blood pressure medication. Your iron is low. You need some iron, This is the art of medicine, right? You've got heart disease. You need these medications to prevent the next heart attack. You've got reflux. You need a proton pump inhibitor. So when did we become society that decides that all these drugs, the Prilosec combined with the cholesterol medication, combined with the hypertension, is a no-no, and we should be contacting the FDA now to get approval by the FDA to combine all these drugs? Never. So yes, you can hear my tone of frustration because what was attacked during the pandemic was the art of medicine. When they attacked these doctors and called them names because they were trying to save lives, they killed the art of medicine. They killed the courage of a doctor to go outside the box. And here's what happens now. These doctors are left on the front line with cancer, and they're struggling to find answers for you. And there's others that are coming out and saying ivermectin, fenbendazole. But here's the problem. Where's the data on ivermectin, fenbendazole? How do you convince a group of doctors that ivermectin, fenbendazole has merit, right? Because nobody's doing the real research where you're looking at at endpoints. Nobody's doing the blood test. Nobody's checking the CEA monthly and writing the data. Nobody's taking an informed consent of the patient that they're on ivermectin, fenbendazole. Nobody's looking at drugs and the connection with other drugs. Nobody's looking at the microbiome on those patients.
So let me hang on a second because I got your passion. So first of all, it's obvious to me. I mean, I also treated people during COVID. I listened to people like you and Dr. McCullough and stuff, and I winged it in the office and
went with your gut feeling. I wouldn't say you
well, I've been in integrative medicine for 43 years, so I don't use as many drugs. I'm usually doing the opposite, trying to peel people off. So when I was using multi-drug therapy, it was rather nerve-wracking, plus everything else. But I learned from people like you and Dr. McCullough and the FLCC, et cetera, et cetera. It's obvious to me why your work got suppressed. I mean, I think it was a planned pandemic, and I think that you had to get the vaccines out, and there can't be any, emergency authorization use didn't allow people like you or Dr. McCullough, et cetera, to do that. So they have to be discredited, because otherwise you couldn't have rolled out the vaccines in the way they did, and et cetera. And we'll get to the vaccines in a minute. But I have one thing before you
But
forget.
that's the control of medicine, right? That's corporate America in
It's
action, right? It's this big machine that we created that basically looks at the price of a stock of a company and therefore wants the company to keep succeeding because it provides jobs for people, right? So it's a catch-22, right? So it's like you want to push the companies that have a lot of employees because you want to support the jobs and the economy, but at the same time you're not looking at the proper research, the proper science, and I think that's where everything went wrong. I think
that it may be, well, all right, we can go around on that, but I would say this. I've been in this medicine 43 years. I go back to the days of Linus Pauling Institute, where he used doses like you're using in that trial. That's what got me very interested. You were using 10 grams in your to increase Bifidobacteria.
I was using 3,000 milligrams of vitamin C. But
well, in
in
the one study,
vitamin C increasing bifidobacteria, some patients were taking 10 grams. Yes.
yeah, I was looking at your charts and I'm going, those
And
aren't.
I don't recommend 10 grams on anybody because I do believe there is still a kidney problem because listen, we just figured out, and there's a great study that came out that showed that kidney stones is the loss of microbes, right? So are we giving vitamin C to people that are losing those microbes and therefore increasing other microbes that are accumulating kidney stones in the patient's kidneys? Those are good questions and good studies to do. So I think everybody's an individual. I think everybody has a fingerprint of a microbiome. And I think the future is going to be going to figure out that fingerprint, figuring out what that person is missing for their genetics or for their, where they were born in the region of the world, and then replenishing those. That's probably the future that's going to happen, more precision, right? In other words, don't kill a bacteria with a broad spectrum antibiotic. Focus on the microbe that suppresses that bacteria, which is one-on-one. Basically, what I did with COVID was figure out what microbe is lost in severe COVID patients versus what microbes are alive and well in people that were exposed to severe COVID patients but never got COVID, right?
So how did you how did you, in your COVID treatment, I never got how you refluoridated or how
so the idea was basically kill the virus. So I stratified, right? I basically looked at my population. So let's say you were a patient that came in with cancer, elderly. I assumed you had zero bifidobacteria because we demonstrated in abstracts that we presented at the American College of Gastro that invasive cancer was linked with loss of bifidobacteria. So I assumed you had zero bifidobacteria. Now, how am I going to implant bifidobacteria when you're in Nebraska? First, I'm going to kill the virus because I know the first thing, a virus penetrates in a gut that has zero bifidobacteria, that patient is dead. So in my mind, it was like, let's kill the virus quickly with the hydroxychloroquine, and then let's start boosting the microbiome. We came to discover vitamin C, D increased the bifidobacteria. Zinc improved the firmicutes, the Baciata, they call them now. And so vitamin C, D, and zinc was really my combination vitamin that we used to shut down, to basically improve the gut as we were killing the virus and killing the gut, because we discovered that hydroxychloroquine and Z-Pak also kills the virus, but kills the microbiome. So you need to boost it. Now, ivermectin was an interesting one because it didn't do that, but it also didn't eradicate the virus completely. So in some people, the virus could still be lingering, causing problems. And the problem with ivermectin is very short acting. So it increases the bifidobacteria, but then the next day it drops even lower. So you're constantly battling and you're never engrafting. Vitamin C, D, and zinc increases, vitamin C and D increases the bifidobacteria, but again, increase, drop, increase, it never engrafts, okay? So this was kind of the path of discovery. How did I lose no one? Because I started with, what do I think my patient's bifidobacteria level is? If it's a kid that came to me, I assumed the kid was healthy, never had any problem. I assumed they had a lot of bifidobacteria. So I said, you know what? I don't think you need anything except some good vitamins. If it was a person I wasn't sure of, I was probably going towards ivermectin, doxy, zinc, vitamin C, and D. If it was a person that was really debilitated, I went for the guns, right? Which was hydroxy, Z-Pak, vitamin C, D, zinc, and I even added ivermectin in some patients. So it was really a, kind of assessment of the patient that made me kind of figure this out with COVID.
All right.
I get passionate and
I know. I think I've reignited the emotion there. I mean, and I get it. I get it. I guess what I was trying to say is that
what was really why you ignited that is because it was very frustrating to be a physician on the front line and to try to figure out how to develop a protocol to treat patients, losing no one and not being heard. That was what was frustrating, because I have a girlfriend who lives in my neighborhood in Malibu, and she basically said, if I had the cure for COVID, I would be screaming it from the top of my lungs. Well, I tried to scream it, and nobody wanted to listen. And even though I treated thousands and lost no one, nobody wanted to listen, because it didn't have a price of a stock linked to it. It didn't have a company that was sponsoring my studies.
okay.
And so it was frustrating to get to that level and to basically not be heard.
So to re-inoculate these people or to help them get bifidobacter, you didn't give a bifidobacter supplement. You used the nutraceuticals basically and a little bit of drugs. Is that correct?
Well, here's what I discovered. It's not so straightforward. Okay. It's not so straightforward because you have to look at the microbiome. The microbiome test that we do is a research tool at best. It is not a consumer product. All those consumers products out there have no clinical data, no reproducibility. And unfortunately, that doesn't help you. I mean, you're a functional medicine doctor. You could look at these stool tests and just tell me, what does a normal microbiome look like? You cannot tell. And when these companies give you a normal, well, how could there be a normal when the microbiome is different in every one of us? When our ages, there's an age difference. The bifidobacteria level of a baby versus an old person is completely different. So where's the normal there? 0 to 100? I mean, come on. So how is there a normal? The other thing is, what disease do you have? If you have a certain disease, your microbiome looks completely different than another person. What race are you from? Are you from the Amazon jungle? Or are you from Africa? Or are you from Kansas City? Different microbiome. So until we get that research, until we map the microbiome of humanity and figure out this is what the microbiome of Italy looks like, this is what the microbiome of the Amazon jungle looks like, this is what the microbiome of Chinese people in China looks like versus Chinese in America, right? Then we can advance the science of the microbiome and we could say, okay, well, let's look. What I do in my lab is really at the research level. I test the microbiome, I test the bifidobacteria, and I assess what is my level accurately. And then I decide, does that patient need probiotics? Because if the patient needs probiotics, if he has 0 bifidobacteria, he needs probiotics because he doesn't have the seeds. If I'm trying to grow tomatoes in my garden, I'm not going to be able to grow them if I have 0 tomato seeds in the grass, right? They're not just going to grow. So if a patient has 0 bifidobacteria, I'm going to give them probiotics. but I got to follow to make sure that that probiotic is engrafting in the colon and is actually latching on. And then the big question is, does that probiotic need to be taken every day the same? Do I need to rotate? There's a great company out there that's actually doing rotation of probiotics. That's a great idea. Maybe that's novel. Maybe that's going to do something, changing, our diseases. The bottom line is there's still a lot of research that needs to be done. So for me to tell you, how do I engraft? How do I implant? We're still at the level of, we don't have a genetic sequencing test that is valid and approved by the FDA. That is still research. So people that come to me, they come under research. If we don't do the research, the problem that happens is we lose the momentum, we lose the ball, and then it gets killed by other companies that are there to suppress your product so that they can come out with a top secret ivermectin fenbendazole drug for cancer. So we need to do the research properly.
I haven't got the answer to that
And,
one.
and by the way,
I guess what I'm saying, I just want to, as a practical clinician, forget about all the politics. Practical clinician, you wanted to re-inoculate the bowel. You gave him something, right? Was it a bifidobacteria product? I mean, you can just say generically.
Listen, I treat everyone differently. I take a history. Okay. So I'm not going to be here influencing people on, hey, drink this yogurt or drink this drink or do this protocol, because everybody is different. And I think this is where functional medicine doctors like yourself and other doctors need to come to me and say, hey, Sabine, we want to work together. Let's see what you're seeing, so I can train you with what I'm seeing before it gets written in the data. I spoke at the WIN Consortium last week in Philadelphia with Dr. Alderi. And it was actually amazing that I connected and I got the attention of him, because he's the top guy that was behind P53. He's the top guy at Brown University that's innovated treatment, that's innovated, lab test, right? And he works with other doctors that are in that position, the head of Harvard, the head of, Penn State, the head of MD Anderson, all these centers where people go to for hope, because these people have gotten a position where they are now responsible to innovate. And let me tell you, these doctors were very open to my work. And they're working together. We're working together now. I'm working with Penn State to advance neuroblastoma, to test the microbiome of kids with neuroblastoma. This needs to happen. You want answers on colon cancer. You're taking a drug, ivermectin fenbendazole. Let's see, where are you at with your CEA? Where are you at with your cancer? What does the CAT scan look like? And what does your microbiome look like? Because maybe what you're doing is maybe you're improving the cancer and shrinking the tumor, but what are you doing to your gut? Are you killing your gut? And therefore, the next virus that's going to come around is going to wipe you out, because great, you've survived the cancer, but now you're going to have a virus that's going to kill you, which is the number one way, by the way, people die from cancer, is infections that kills them. Therefore, we're not looking at the microbiome. We need to.
So I have no, okay.
Sorry, I don't mean to be so tough, but
No, I've done all those things.
I have to defend the science, and I have to defend the art of medicine. And I have
I get it. So asking at your facility, do your functional medicine doctors send you stool exams for their patients?
Absolutely. And we look at it together. Absolutely.
Right. So that's something, I would always do. I gave up doing stool exams because I just get, it's way art of medicine. Let me put it that way. To guess if there's something from there. And I've done that a long time.
We work together, right? That's why you give an informed consent to the patient. We give you a consent actually to give to the patient that basically delineates the risk benefits of taking a stool test and where we're at, that it's a research test, right? So once you give that consent to the patient accepts to do the testing, They're going to you. I'm reviewing what I see with what I know from the microbiome so far. I mean, we're so far from understanding these microbes, but I'm working with amazing physicians and scientists who have worked in the government to kind of like get us to there. So I'm not shy to ask questions. I'm not shy to say, I don't know this. I don't know why it worked. Listen, I was arguing with Dr. Barodi on ivermectin, and I was saying, Dr. Barodi, it's too high of a dose, 36 milligrams. Are you kidding me? And then I gave it to a patient of mine that couldn't breathe, and oxygen was in the 70s, and his oxygen improved. So I learned something, but I had to listen to Dr. Barodi and have a leap of faith, right? That I could do it. Somebody gave me courage to do that. I think, where we're at with ivermectin and fenbendazole is great because there are some doctors that are using it, and there are some people that are living a little bit longer. We just need to figure out at what point do we need to stop? At what point do we need to switch to something else? Because right now you're in this conundrum of it's working probably, right? Because otherwise we wouldn't be here, right, Kirk? Is it working?
Well, there may be a variety of reasons why I'm here, but let's. So let me go. Because I want to
But
get
if
to.
it's working, you want to know how long do you need to take
Right.
this?
So I mean, let's just do my case real fast because otherwise we'll go back and forth. Because
Because
but
I'm
I
obviously
have
very interested. This is fascinating.
right. So essentially, I followed the FLCC, Peter McCullough, all those kind of people, and I was going through the long haul and with them, and then I was hearing about using ivermectin and starving the cancer cell with the ketogenic diet, that kind of stuff. And in our clinic, people would come to us for adjunctive care, and we just do IV vitamin C, and sometimes they just do whatever they did. But lo and behold, I get cancer. And I had the vaccine back in January, February of 2020,
20,
2021.
yes.
Yeah, 2021. And I never get vaccines. I never do. And I did it because I knew there was going to be lockdowns and I want to go on a trip. And I said, it's not going to hurt me. I'm going to take my IV vitamin C and blah, blah, blah. So anyway, in August, 5 months later, I got COVID, treated myself. We were not sure how to do it here. So I was the one who did it here in the clinic and started treating myself. And it was, with just ivermectin, zinc, doxycycline, and the nutrients and IV vitamin C, no problem. Back to work. And so then I started to open up treating other people and following the protocols of McCullough and Peter McCullough and the FLCC, very similar to what you're doing. So anyway, to make a long story short, that was really intense. And I changed my diet. I went from a plant-based diet to a very poor diet, very stressed, and just whatever. And so I noticed I was having some IBS symptoms
At that
for a
point,
while.
did you have cancer? Not yet.
No,
Right?
well, I probably did. Well, you're the gastroenterologist. So we went through that whole thing and I'm practicing. And then in August of 23, I switched over from Kaiser to Medicare, and I noticed I had some cramping, and it was a different kind of, like, it wasn't just IBS from my one cup of coffee a day. It was something different, and I felt it right across my upper intestine. So I did a stool exam, and one of those stool exams, and there was blood in it, and there was no pancreatic elastase. And so I then did a Cologuard, and then I did a colonoscopy, and by 2 years ago, almost to the date, I just had my one year follow up, but I did a colonoscopy, and it was 6.4 centimeter mass in the hepatic flexure. And you wake up and the gastroenterologist goes, "Here's a pretty colored pictures, and we're going to send you to get cut out of 12 inches of your colon, and then we'll do chemo, and you'll be great." Well, in that process, a couple months before that, I started to.
Was it so? First of all, had you had a colonoscopy prior to that, or that was
No,
your?
so I never had a
How old are
colonoscopy.
you?
I'm well, I'm 68 now, so that was 2 years ago. Yeah, so that's
So the
66.
guidelines right now is 45. People should have their colonoscopy by 45. Okay.
So,
All right. So, okay. The second, and I say that because I'm hoping your case can help others, right? So the second question that I have is, was it localized or was your CA elevated?
no, so immediately when I I did actually the CEA because I thought I did lipase amylase, and because I thought it might be pancreatic cancer because I know elastase. But anyway, I did CEA's never been elevated. It was never elevated.
Okay.
Now, also, I've been taking on and off ivermectin because I was treating people, not high dose, but just prophylactically for really since August of 21, to be truthful.
Okay.
I mean, it wasn't like every day, but it was
Once a
a couple
week.
times a week. Yeah,
Okay.
as a prophylaxis. So I was in the midst of learning about the alternative repurposed drugs, and at that time, the conferences that were doing the long haul. Now, then it was long haul, then it was vaccine injury. They were starting to get into it, Palmeric, et cetera, and reading other people. So I decided when I got the diagnosis that I have access to high dose vitamin C here, so I do that. I did that 4 or 5 days a week. You see the IV pole behind me. I don't do it as much anymore. I did ivermectin. That's what I tried. Albendazole, fenbendazole. Albendazole and fenbendazole make my liver enzymes go up. So
Yes.
mebendazole did. And then I did some other things like low dose naltrexone for a while. Even some of the erectile dysfunction drugs, because they're supposedly so about 3 or 4 minor ones, but the big ones were ivermectin and uh, and well, fenbendazole I tried, but eventually mebendazole. So I did that, and I did a very I was an intensive meditation program. I felt like to me that was the gift of my cancer. I'm not upset that I got it. It may sound weird, but I'm not, because it's changing my life to do stuff like this again, get back to what I love to do, which is share information. Um, so the concern was as a gastroenterologist and all the medical people around me, and I didn't just wing this. I went to everybody, it says, hey, you got to get it cut out. You could rupture your colon, you're dead, not from a cancer, but you're dead from sepsis. And so
Right.
that's what was hanging over my head as I tried to do this. And so I did a 16 months later, I could not shrink. I could not shrink it. And I got up to some,
You didn't resect it?
no, not at the beginning. So I
Oh,
had no metastases. I had about had about 10 CT scans, and I had about 4 or 5 PET scans. And every time I'd go in, my oncologist would say, Kirk, something's going to happen here, and you gotta do something, and surgeon and everybody. But I wanted to, if you came up with something, or you believe in something and treating yourself,
well, you
I wanted to.
basically, what you did was you were the guinea pig on the front line trying to prove your data,
Well,
right?
I will,
Right.
yeah, in a
But
sense.
here's the problem. And I have people that come to me all day long with a stage 1, I would say, cancer, and then they don't do the resection. And then what happens is they end up getting worse. And I have to bang my head on the wall because the whole time I'm like, why didn't you do the resection? Right. I have a woman with stage 1 that had a stage 1 breast cancer. Okay. And I get it because there's no trust in medicine anymore. There's no trust in COVID killed whatever last, trust of doctors, it killed it. Okay. When we attack vitamins, when we attack, probiotics, when we attack natural ways of healing, then we also destroy the faith or we destroy patients' confidence in doctors, right? I think there's a role for nutraceuticals and there's a role for drugs. I mean, ivermectin's a drug, right? And vitamins are nutraceuticals. So I, you know, if you were my patient back then, I would have told you, get that thing out ASAP.
Trust
Okay.
me, they all did. They
And
all
by the
did.
way, I had that patient. Okay. I had a patient like that one year. He was so scared of having a colonoscopy. And listen to this case. He was so scared of having a colonoscopy that he would come to me and say, I'm dreaming that I have colon cancer. I'm like, well, then get a colonoscopy. And then one time he comes to me and he goes, I'm dreaming of crows and, I'm dying with colon cancer. And I'm like, get a colonoscopy. And finally, we kind of like forced him to do the colonoscopy, after like screaming. And then, because I'm like, I don't want to see you anymore if you're going to come and tell me your story that you're scared about having a colonoscopy. And unfortunately, I have to be tough because the fear of having colon cancer blunts the judgment. And so I'm sitting on this side trying to help you. And you're so scared that you don't want to have the colonoscopy because you don't want to be diagnosed. Anyways, this guy ended up having, rectal cancer, mets all over. He was dead within a month. And the whole time I was like, could I have been more forceful? No, because I'm the girl that's like super tough. Listen, I was during the front line. People were scared of taking hydroxychloroquine. Okay. One of the guys, he talked about it on the Dennis Prager show, and he said, and literally for a week, I was babying him with COVID. And finally on a Wednesday night at 2:00 in the morning, he can't breathe. He's short of breath. He's like, he's about to crash. And I said to him, I go, how long is it going to take you to take the hydroxychloroquine? Are you waiting for me to bury you tomorrow? I'm like, take the pill or you're dead tomorrow. I have to talk to my patients. One patient, by the way, thanked me to this day because I literally told him, either you take the treatment or you're dead tomorrow. Don't talk to me. Don't call me. And he called me back alive, obviously, on his birthday a year later. And he goes, by the way, doctor, thank you for being so tough to convince me. It's hard to convince. I have a breast cancer patient who, if I showed you the picture, you're going to go, oh my God, what happened there? She went the fenbendazole ivermectin route, and her stage 1 cancer is now coming out of the skin, completely broken out, and it's horrible. And I cannot help but wonder what happened. Where have we gone wrong as physicians that we stopped following, we stopped being courageous, and we stopped following the guidelines at the same time, because I think you have to stay within the boundaries. I had a patient with Crohn's disease right before I talked to you. I talked to her functional medicine doctor. And the patient's microbiome is getting worse. Okay. And I said to the woman, I said, unfortunately, I'm seeing a picture of a microbiome getting worse. She cannot get off her biologic. We're not at the level where I could do fecal transplant on this woman. She doesn't have C. diff. I'm not about to write a $30,000 protocol to submit it to the FDA, which is going to end up costing me about $500,000 after, when all is said and done, like I did with autism. Autism, the one case we submitted for fecal transplant for familial FMT for autism for an N of 1 ended up costing hundreds of thousands of dollars. And then when we tried to go from N of 1 to N of 30, that was 5.5 years of my life fighting with the FDA and over $600,000. But guess what? It needed to be done. Now here's the big challenge. We have to raise $3 million to hire the gastroenterologist, the pediatric gastroenterologist in New York, in Florida, in California to run the study, the pediatric neurologist to do the CARS testing, the ATEC scores, the monitors, the coordinators, all these people are like hundreds of thousands of dollars per year per site. So we need a lot of money. It's not easy. None of research is easy. But here's what's harder. What's harder is dealing with a patient who listened to the noise, who feared, going to the doctor for stage 1 and watching him die with a cancer that's spreading because he didn't listen to that stage 1. And I really believe, where are you at with your cancer, by the way? Is it shrinking or did it spread?
So well, I just I hear your passion. You don't know the side roots, but it's not something I just took on lightly. Trust me, I did everything.
Listen,
I had multiple visits. So my cancer is now. So what happened was 16 months after the original diagnosis, I was doing these things and I was losing weight. I'd lost a lot of weight. And it was a standoff. Again, I said I had 10 CT scans over that 16 months and 4 PET scans. There was never any spread. The concern was Kirk is going to rupture sometime, and it grew a little bit, but not anywhere else. So finally, I just said, hey, God, if I'm supposed, because So a little bit differently, I didn't do this just because my ego says I don't want to have surgery or I don't want to have treatment. It was in our medicine, I see the cancer conveyor belt. I just want people to have options, and then they choose what they want to do. I never tell anybody what, I tell them to go get the diagnosis and everything. But so what happened was, um, someday we'll talk about high dose ivermectin because I've taken more than probably anybody. But I decided that I actually got a kidney stone, and I went in after I'd canceled the surgery in January of this year, and the doc goes, you just have a kidney stone, and I go, I'm ready to go. So anyway, I got the surgery done. I was, probably 20 pounds lighter than I was now. He actually is an old school guy, old school, been here for 35 years doing these surgeries. The hospital said, the nurse said, I don't know what we're going to do when he leaves. So anyway, he cut it out. It was an 8 centimeter mass. It was supposed to be into being an intussusception, but he said, no, I think that was BS. I think it was just a big mass. So he took it out. There was one node out of the 22 he took, negative. I had a follow-up CT scan in August, clean, and I had a follow-up colonoscopy just 2 weeks ago, clean. So I tapered down my dose. I'm because I of the ivermectin and mebendazole, and I'll probably take it. I've been asking this question to myself about what am I doing to my microbiome since a year ago, but I didn't have you in front of me, one of the world's experts, to ask the question or to go to your lab and do it. I'll do it. I have no problem with that.
And by the way, because you were so courageous to take on this experiment on yourself to help the world, I'm happy to do the testing for free. So just send me your food,
no,
and
but I was
important. It's an important finding. I wish we had the microbiome of the tumor, to be quite honest, because now I actually want to look at the microbiome of the tumor, because there's a thought that all these tumors have microbes in them. And I think that's the key to basically preventing colon cancer in the future. There is going to be a time, I'm not going to say right now what I believe are the microbes involved with colon cancer, but there is going to be a time where we are going to have a signature microbiome for colon cancer, of lost microbes and overgrown microbes. Look at H. pylori, H. pylori, gastric cancer, HPV, cervical cancer, EBV, Burkitt's lymphoma. I think there's going to be a time where all these microbes, all these tumors are various microbes. And it's just a question of pinpointing it. We're looking at GIST tumors right now, and we found a specific group of microbes with GIST tumors. It's something that obviously needs a lot more work, a lot more testing, a lot more, validation, verification, reproducibility by other labs. But this is an exciting world. And I think there's a purpose to getting the stool samples now after the surgery. Did you have chemo or you didn't do chemo?
No, so my oncologist is dearest person. They want to do chemo, and she said it's only going to be she said it's going to be 10 to 15% maybe increase in 5 year. And I go, I wasn't going to do it. I was just going to lower my dose of the.
I think that's reasonable. I think like the surgery was the most important part, and you remove the tumor and your lymph nodes are negative. I think, you should still, in my opinion, look, you made an informed consent. That's your choice, freedom of choice. I commend you for that. But I think you should take a look. We should take a look at your microbiome.
No, I will. I'll pay. I have no problem with that. That's, in fact,
I would go back to your oncologist, by the way, because I'm not the girl that's the oncology with chemo, but I would ask him, what is the data of, decrease reoccurrence of cancer if you got the chemo? Because I think that's also
10 to 15%, 10 to 15% versus doing nothing. I love her to death, but I'm not afraid of the cancer right now. That's not my biggest issue in life. Truthfully, it's to keep changing my head up here and living my purpose. And I really believe that, but I wanted, no one, so there's not a whole, there's a lot of people who take these medicines, and some If the anecdotal reports are true, there's a fair amount of people who improve. Okay. So the
And
question
those
is,
are the people I told William Mackis and all the doctors that are treating cancer, send me their stools,
no, I
please.
get it. I follow either Dr. Mackis is either creating stuff or these having some results. And I that's the first thing I've told my patients when I share that with them. I go, we don't know what happens when you continue to take this. So I've got to hear, I want to get off these things. I don't want to be on anything. That's my whole
Right.
principle of being in this kind of medicine, to be truthful. So I want to ask one thing. You've been so gracious with your time, but it's really important. The spike protein, you even called this, spike protein diseases, long haul, etc., and vaccine injury. So my question is, you got into trouble, I think, saying that the vaccine, the messenger RNA vaccine, decreased immunity. There's something you said they didn't like.
Well, there's a lot of
um,
things I say that they didn't like.
I
So
know, but it's related to the vaccine.
but then afterwards they think about it and they're like, maybe she's right. We show data that the messenger RNA vaccine kills the bifidobacteria. Bifidobacteria being this important microbe that we found was lost in severe COVID patients, in Lyme patient, in Crohn's, in invasive cancer, in long COVID, in um, Lyme disease, in bipolar disorder, in anxiety, in absorption, bifidobacteria that helps you absorb sugar. When people talk about mitochondria, well, the whole ATP and the whole Krebs cycle is great, but if you don't have sugar going into the cell, and if the bifidobacteria doesn't help break down that sugar, then no sugar going into the cell, and good luck with your mitochondria. So I think we need to start paying attention to the microbiome. We need to pay attention to bifidobacteria, in my opinion, specifically. That's my research. I always say it's all research. Prove me wrong. If I'm full of it, then be it. It was all research. It was my idea. Believe me, there's nothing worse as a physician than coming out with an idea that you think you're on the right path, and you keep going, and you have to constantly ask yourself, are you sure you're on the right path? Am I sure? It's not an easy feeling, because you're kind of like, I'm driving this force of the microbiome. To me, that started with a patient of Alzheimer's that improved his improved his microbiome and remembered his daughter's date of birth. So to me, the whole brain gut started happening. I saw it with fecal transplant with an N of 1. But can I say with certainty, if you do fecal transplant, you're going to improve Alzheimer's? No, we need to do the research. We need to do the data. I, of all people, know what it takes to do research. I'm the girl that basically brought clinical trials to market for pharma. So I'm the girl that knows from the moment you think of an idea to the moment it becomes a drug that's in the guideline, it's at least 20 years. And actually, it's even more now. In 1957, Dr. Fred Einsman came up with the idea of doing 2 enemas for patients with C. diff. And that was his idea of doing fecal transplant, right? Taking the stools of a healthy donor that he thought was healthy, putting it in a patient with C. diff, improving C. diff. He published it. 1980, Dr. Barodi, who just passed away sadly, came up with the idea of, let's do fecal transplant for other diseases, because all disease begins in the gut, right? We all were taught that. So what happened is, from 1980 to last year, the guidelines just finally approved that fecal transplant is approved for recurrent C. diff. So it took 62 years it took 62 years for fecal transplant to be part of the guidelines. 62 years from the moment Dr. Einsman tried to do fecal transplant on 2 patients with C. diff. We're far from that in colon cancer, but we need to keep pushing. We need to keep advancing the science. We need to keep convincing our peers, because look, we can either say all doctors are horrible and let's just stop seeing the doctor, but who's going to deliver your baby? Who's going to Who are you going to go when you break your hip fracture? Who are you going to go when your appendix is bursting? Who are you going to go when you have a headache, when you have a suicidal ideation? You know what I mean? You still need the field. You still need the doctors, and we need to bring those doctors. What the beautiful thing about functional medicine, and I'll tell you this, I work on both sides, right? I work with pharma and I work with non-pharma, nutraceutical world. I work with the academics, doctors, and I work with the frontline, rebels that are really scientists in the making, like yourself. You're a scientist in the making. You wanted to see what is it doing on your body. Think about what, Epstein-Barr did. He swallowed, the virus to get mono so that he could prove to the world that, his virus caused mono. So this is what we do as physicians. That's what we do on the front line. We want to be that discoverer, that scientist that figures it out, right? But at the same time, I'll tell you, as I work with academia, I worked with a doctor from an academic center who's the head of GI at this academic center. And she called me the other day and she said, what's the best functional medicine conference that I can attend? So it was important for me to be speaking and to be in this middle ground so that I could get the academician to say, what's Sabine doing? What is Sabine doing on her Malibu patients? Why is she attracting all these Malibu clients and these celebrities and high net worth patients? Because I'm outside the box, in between you guys. I'm in between the functional and I'm in between the academic. And somewhere along the line, I found a path to navigate straight so that I could still keep my license. Hopefully I'll keep it for a little bit longer to continue this research, because there's a lot of things in my brain I want to publish. But I think what we need to do is we need to kind of come together, you with what you've done, oncologists with what they've done. Look, the fact that I have Penn State interested in working with me on the microbiome in patients with neuroblastoma, and then there's a doctor that's given, ivermectin, or a doctor that's doing a new vaccine, because we tend to poo-poo vaccine, but it's just a term, just like antibiotics. It's a brand. Not all vaccines are, what they're supposed to be doing, and not all of them are, COVID vaccines on a virus that's mutating.
So, let me ask you this. I need one. Go ahead.
Finish up. That was the whole skepticism for me from day one on these vaccines. Was we found COVID in the stools and we discovered the whole genome, and we found differences in variations, mutations in every person. And what happened is we started asking the question, me and my pathologist, how do we vaccinate? How is there going to be a vaccine that's going to be helpful for every single different virus, right? And because to vaccinate, you need the same sequence as the virus. Now, they took a little piece of the virus that they thought that little piece, that spike protein, is really the piece that everybody has in common. And therefore, we're going to vaccinate against that piece, right? Because in the vaccine world, ABC is your bug. You got to develop a vaccine, ABC vaccine, so you match, so it recognizes. The problem when you use a little spike, you don't know what the spike's doing in the blood. You don't know if it's activating other dormant viruses. You don't know where it's circulating. You don't know if it's going to the gut and killing something. We discovered it killed the Bifidobacteria, and it persisted in killing. There's definitely persistence of the spike protein that is causing damages that Peter McCullough has talked about, and all these doctors.
All right. So is not, though, one of my questions was the spike protein that was made, the messenger RNA tells you to make, is different than the spike protein that's in the natural occurring virus, correct? Doesn't have two proline insertions. I don't understand the biochemistry. They're not the same thing.
Well, yeah, because even the spike protein mutates. Even we showed it on our original data, of finding COVID in the stools. The spike protein is different, as the virus takes on, different shape. So, and by the way, I'm just going to say without saying too much, because, there's a lot of things that are not published, and I try to stay within the published realm of what I publish. We're in the world right now of designer bugs. Okay. We can CRISPR a piece of a microbe and a piece of a virus and put them together and create a novel microbe. This is what was being done. Okay. Now, whether it's in the idea of, hey, let's, see what could happen if we CRISPR, and let's do it in a controlled setting, and then it got loose, and then what, basically almost wiped out humanity. I personally think that's a dangerous research. When you start manipulating microbes and you're cutting a piece of one and another piece of one and creating a new microbe that the body doesn't recognize, what's the body going to do? It's going to fight that microbe, and it's going to kill its own cells to kill the microbe. So I think, we're in the world of designer microbes. We're in the world of CRISPR technology. CRISPR technology may be great at nipping, a piece of a gene that causes the disease. But what's the consequence of that, right? We don't know. It's all research. If we knew what it was we were doing, it would not be called research. Albert Einstein said it.
So are the people that get the vaccine harder to treat than the people that don't get the vaccine?
I've discovered yes. Yes.
Right.
But
so
if
if
you look at the microbiome of long COVID and vaccine injured, they both have, and we're presenting that data at ACG, they both have a leaky gut, a gut dysbiosis.
Mm-hmm. Okay.
And it's not that easy to fix without testing. And yes, you can try certain things, and you can try, it's kind of like putting mud on the wall and expect it to stick. But ultimately, what I like to do is I like precision medicine. I like to test. I like to treat. I give a standardized protocol. And then we see from there, is it engrafting? Because there's so many components to engraftment. Here's the thing, as listening to your story, right? There are some things you probably did, and I'm not going to discuss because I haven't published on what does diet do to the microbiome, vegan, vegetarian, carnivore, ketogenic. But, you probably were raised, I'm guessing, carnivore, right? Was your family big
not
eaters?
not the popular carnivore. I mean, I'm talking about I had, various
like balanced, right? You were like,
right, but for 25 years before I got COVID, it's funny. What happened was I was a vegan, plant-based 95%, and then I got COVID, and for some reason, I mean, I always liked meat, but for some reason, I said, I'm just going to start eating. And not only did I eat meat for those 2 years before, and I'm not blaming it on meat, but I'm just saying, not only did I change my diet radically, but there was also more stressors and everything came together. And then there was the vaccines that got thrown on top of that. And, I mean, I can make a case for that, but, okay.
I
So
don't know, right? Because I don't have your baseline of when you were a kid, but I'm guessing there's probably some things that you did that killed your microbiome that got you to that level. Do you have a family history of colon cancer?
no, but that's a question. So this, like I want to, somebody who followed your work, he was Dr. Zabalos in
Yes.
Brazil. So
Yes.
I
Robert.
was going to ask you. So he gives 5 days worth of Cipro, 500 BID, and then it puts ivermectin, at this dosage, and then a bifidobacter that somehow is whatever. And he does one other thing. And so my question was, and this actually is another question of mine. So he wipes out the floor, and you're saying kids get antibiotics, let's say 2 or 3 or 4 rounds, and they got chronic ear infections. How long you can't judge how long that dysbiosis lasts, right?
No. So here's the thing. Some kids, they bounce back after taking the antibiotics and they're doing great. Now, remember, Dr. Zabalos and I are doing the clinical trials where I'm testing the microbiome before and after. Because he saw the clinical, I want to see the microbiome, because the microbiome tells me the story and tells me, where are we at? If he wiped out, Cipro has some problems, right, on the microbiome. I have a kid right now that I cannot get back, into, living, into getting out of his bed, into civilization again, going outside. And he got a bunch of Cipro and he's just wiped out his gut completely. I don't know how I'm going to bring on that case with the FDA to allow me to do fecal transplant on this kid. But the fact is, he wiped out his gut completely. How am I going to replenish that? This kid is like 2 years bedridden right now, right? So there are problems with Cipro. Why I'm doing this protocol with Dr. Zabalos is exactly that, to see the data. Are we wiping the microbiome? And are we sterilizing people? And is that why they're feeling better? So let me just tell you, Kirk, there's a role to sterilizing and there's a role to not sterilizing and having diversity, right? You can live for a long time probably with a sterile gut, like you can live for a long time with a diverse gut. The problem is when you go from sterile environment to a diverse environment like the Amazon jungle, good luck. I mean, because you're bare and you have no microbes to sustain you to survive all the microbes that are going to attack you, right? So, we have to be careful when we talk about, how do we treat? So there's two thought processes, right? There's the thought process of complete sterility, but then when you get out of that environment of sterility and you change and you're in the jungle, you're going to be having problems. And then vice versa, coming from the jungle and coming to a world where you're sterile and everybody's washing their hands with alcohol or soap. I think of the Amazon jungle woman that comes into New York City and takes her first shower and all of a sudden wipes out all her microbes that she accumulated for a lifetime in the jungle on her skin. She did that with one shower. Now, that doesn't mean that she's any less healthy. That just means she's getting adapted to the American microbiome, right? So think about what evolution is and what adaptation is. It's all about, wiping something and slowly re-entering a new environment and adapting to that environment.
Let me, I'm gonna let you go here, but there's three quick observations. One, when I did, the prep for the colonoscopy, the first time I was, but when I did the prep, my stools actually got better after after you did, I go, they formed up. And so you always hear the colonic cells can rebuild in 4 to 7 days or whatever it is. But so did I wipe out some bad bacteria for a while?
Microbes. Yes.
I'm sorry?
You wiped out some bad microbes.
Because that's what it felt like. I go, that was it. Fasting. So I did. I do.
By the way, I have people that take the prep and they feel bloated right after, and they wiped out their good microbes too. So, but the good news with the prep, it's temporary. It's 24 hours. Actually, it's more like a week later, it comes back to normal.
How about fasting on the microbiome? So I did prolong the fasting mimicking diet, and I did some water fasting through this whole year and a half, 4 or 5 days worth. What does that do to the microbiome? Nothing.
I can't really comment on it because I don't have enough data. I've only done probably about a dozen patients fasting, so I'm not going to comment on it.
The last one is
I don't have all the data. And even the data that I have, it's still small numbers. So I encourage everyone to just do more.
I got it. When you were being interviewed by Jan Jakalik from Epic Times just recently. So that's why I listened to that over and over again. So it was interesting. You went back and said you swore that one of the mothers said fungus treatment and it helped him, help the child.
Oh no, yeah. So there's one kid. So there are some parents that are using antifungals for autism, right, and they swear by it. But I think what happens there, the microbe was probably a fungus that created the problem to begin with. That, and by the way, we're noticing with autism, it's not one microbe causing autism. It's multiple microbes for different kids.
So 20 plus years.
What makes it even more complex is that it's one microbe that could be good for one kid and causes autism in another kid, which is really interesting because we're all different.
Well, it was interesting 20 plus years ago when I was going to the Autism Research Institute meeting, like Andrew Wakefield spoke there and such. They were started to do organic acids. That's where it came from because they noticed the fungal metabolite go up in the kids that had chronic antibiotics, and they married the two together. So some autistic kids respond to that. Anyway, I'm very happy that I got to interview you and talk to you because I see your passion, and there's you're trying to marry both sides, not marry, but be an interchange between both sides
I'm trying to stay balanced. I'm trying to stay balanced in the science. I'm trying to stay balanced in my microbiome. I'm trying to showcase the balance, really. It's not all, I think we forget about balance. I think and especially with everything being so politicized, people are either on the right, on the left, and they don't come together, and we've lost humanity. And we've lost humanity, first of all, because we've destroyed the microbiome of humanity, but we've also lost the human touch and the human care and the heart of humanity. We need to bring it back. So,
all right. Well, I thank you.
More empathy, more compassion, more peace. That's what I want.
And I'd like to thank you, the audience, for listening to this edition of the Staying Healthy Today show. Until next time, stay and be well.